Welcome back to Dental XP. I'm sitting alongside this afternoon Dr. Kirk Pasquinelli, who actually went to the University of Washington, and I guess we have some almost common teachers and really common philosophies from the two schools having gone to Penn.
Yeah, I would agree.
Remember Saul Schluger coming in and spending 3 months with us, and I think Ed Rosenberg used to come up there and spend a month.
Eddie used to come and teach us some things and harass us a little bit.
Create chaos.
Yes, definitely.
And what we're going to share with Kirk, what Kirk's going to share with us today is really attending to some of the demanding aesthetic issues that we all encounter on a day-to-day basis. Someone put an implant in, of course it's never us, and it went awry, and you've now got one central incisor that's 10.5 millimeters long, and the other one that now extends beyond the vermilion board of the lip, and you don't even know if it's 15 or 17 or 18 millimeters long. And what exactly do we do for someone who really has a dentition that's in any other respect really non-compromised, and of course always has that high smile line?
Of course.
Share this one with us.
Well, you know, and not only does she have a high smile line, she's an attractive young lady who really is distraught over this. But, you know, she's a reasonable person. You know how sometimes you get someone in who might not be so reasonable, but this person is reasonable and has a legitimate concern. And we can see her presentation when she first came to me. And if we look then at the radiograph, and with her lips out of the way, we can really get a sense of what's going on. And as we spoke a little bit ago, we're certainly not wanting to take that implant out.
No.
That's a very solid, well-integrated implant. It's to or past the base into the nose, into the nasal cavity, and it's certainly a very strong implant. But when we start to wonder about why is it that this one is longer than the adjacent one, and it could be deeper, or it could be more facial. And this one's problem is really that it's placed too far facially. And we knew getting into it that the tissue was very thin there. And so when we made our dissection into the area, we kept it intentionally very thin, because I split that. So the idea being that we had a healthy implant, and we didn't want to disturb the attachment, whatever it might be, to the facial of that implant. And certainly we don't know what it is. But the idea is that we're going to add not only soft tissue back to make the two centrals look alike, but we're going to add something that, some bulk to the bone. So we're going to use a bovine bone graft with the intention of having it surrounded by soft tissue, you know, dense connective tissue, knowing full well that we're not going to get new attachment to the implant. But that's not really our goal, since we seem to have a healthy attachment already. So the first step after the dissection then, and let's actually talk about the dissection a little bit, because what I've found is that if we place our verticals right at the mesial of the two adjacent teeth, that we don't have enough relaxation in the flap, and we don't have enough ability to get closure, good closure over the top. The other thing that we do before we start this procedure is that we have the restorative dentist, in this case a prosthodontist who sent me the case, inherited from, the work was done in Southern California, and then she moved to Northern California. We have him take the provisional off, take an impression, and then he's going to make a new custom provisional crown with the proper dimensions that I'll place when I uncover the implant.
So you can do this in a two-stage procedure now.
Right, we're going to cover this implant, we're going to let that mature, and then we're going to uncover it and place the provisional as the healing abutment. But all that has to be made first, so he takes an impression before I do the surgery. And then I actually had him remove the provisional prior to the surgery and make a flipper for us and let some of the tissue collapse over the cover screw, which he placed, giving me more tissue to work with as well.
So you then basically sterilize this implant down the cavity with tetracycline or something.
Right.
But a graft on there that looks like a xenograft, is it?
Yeah, that's bovine bone mixed with some calcium sulfate, pure calcium sulfate, and to give it some adhesiveness and And then all the good things that we've heard about calcium sulfate, in that it is antibacterial, angiogenic, and other things that will help us with healing as well.
And you're really hoping that this stays a long time. You
Correct.
don't want.
Correct. We don't, and that's why the bovine bone is good for this purpose, because we just want it sitting there, basically. And so that's the first step, and then I like to use a relatively short resorbable membrane over the top of that to isolate the bone from the soft tissue.
And you tack that down or not necessary?
No, with this particular membrane, it is somewhat tacky once it's been hydrated.
So what
And
membrane are you using here?
This particular membrane is a BioGuide membrane.
Great.
And so we'll hydrate that with a tetracycline or a penicillin solution. Yeah.
Great.
You know, years ago I saw a lecture from Eugene Roberts, I'm sorry.
Roberts, right.
Yeah, who was a bone physiologist. He used to be at the University of the
Clever man.
Pacific. And I was impressed because he was showing slides, histo, of bone that he had labeled with tetracycline so that you could see the sequential growth of bone. And somebody in the audience said, well, you know, I always mix tetracycline with my bone grafts. And he stopped the lecture, he looked at this person and said, tetracycline is bone poison. You should never mix it with your bone grafts. And of course we were all mixing
Absolutely.
tetracycline, and I thought, well, why? And so I sort of gotten away from adding tetracycline to the bone grafts. I'll use it as an irrigant for root coverage and things like that occasionally, or to clean under flaps. But when I mix an antibiotic with the bone graft, I'll typically use something else now.
Penicillin.
Penicillin, yeah. Now, I don't know what he would say about that, but he did say that other about the tetracycline, and so that was interesting. So we'll put that membrane there, and then we'll take from the palate a pure, free connective tissue graft, no epithelium. And the idea here is to close off the access hole that isn't closed at this point, also building up bulk both in the straight facial where we had the deficiency, and then also even in hopefully in the papillas a little bit. Then because of the flap design, we can get very nice closure here, even though we're hiking the flap up on the midfacial. Because it's a split, we can also get the verticals closed back up.
And you're using what nylon there?
This is a combination of a couple of different sutures. We've got 6-0 and 7-0 ethylon. What we found was what we try to do is take most of the tension of the flap in this horizontal mattress here.
Right.
That's a 6-0. We used to use 7-0s for that, but we had a heck of a time getting them out at the 1 week post-op. Yeah, so you've experienced that.
For 3 weeks until
yeah, and this
really
stuff,
shrunk back.
yeah, and this won't resorb, so you got to get it out. So I use a 6-0 there, it's easier to get out, and everything else is 7-0. We've also got some 7-0 ethylon in there.
So you've got a horizontal mattress over the incisal aspect of the incision, holding or coapting the two flaps or holding them together. That's
Correct.
picking up all the tension, and then individual sutures to close.
Correct. So yeah, the tension's on the mattresses. And also, when I first started doing these kinds of procedures, the first sutures I would put in would be the horizontal mattresses right in the center.
Right.
And I learned over time that it's better to close the tops of the verticals first.
It is?
Yeah, and because that takes a lot of the tension right away. If we put this suture and that suture in first, which is totally counterintuitive because you
Right.
want to get all this stuff covered up.
Right.
So you put this one in and this one in first, and you've essentially brought the whole flap down. Then you can put these two in, or three, or however many teeth you're doing, and there's a lot less tension right there. So what I found was that I was losing a little tissue right where that horizontal was until I started doing it this way.
So your first sutures are then in the papillary area on the adjacent teeth,
Correct.
just above, just apical to the actual papilla.
Mm-hmm.
Great
Right.
idea.
Right, sort of a vertical mattress
Right.
in there. And so that's the closure of the first day. And then this is how it heals up at 8 months. And she went a little longer than I think was
healing.
necessary. Yeah, it does look nice. Can't really see the incisions. And nice bulk.
That's a whole discussion in itself. When you make verticals, do they remain? And
Right.
Dennis is doing a study on that right now. Yours have disappeared.
Right, they do look pretty good in
And
that.
we don't know when they do and when they don't.
Well, I could show you some of mine that you could still see.
Right.
So, and then once we're at this stage, we really don't want to take a lot of tissue away. And so we can do a little punch, and we've got the pre-made provisional crown, which we can then place like so. And you can see now from the access cavity where that implant was.
See, 'cause
You know, it was-
yeah, you can see the screw hole coming right through the mid-facial
Right.
buckle there.
so it was obviously facial, and it was even tipped facially as well. And neither one of those things were good for the height of the free gingival margin. You can see the blanching that occurs, and we keep the patient around for 15 or 20 minutes to make sure that that starts to turn pink. And if it doesn't, then we're going to place a healing abutment. We'll back the provisional off, or we'll trim the provisional. But you can see even from this photograph that I've trimmed it fairly significantly.
Yes. The lucky thing over here, of course, is your interproximal has remained remarkably stable before
Yeah.
whoever did it and now.
Right. Right. If we had lost the bone on the mesial of the adjacent teeth, it's a whole different case.
Which is really one of the diagnostic issues right
Right.
at the front. You looked at this and you knew you could do it because it was predominantly a buccal problem.
Correct. Right. It's a whole different thing. As you know, we can get into ortho and all kinds of things if a tooth is wrong.
Really nice result.
And at 3 months, it's looking pretty good. Here's her smile at 3 months and before the initial smile. And I think we've done her a service. She doesn't have the, in these photographs, she doesn't have the final in yet. I understand that's actually being done as we're here at this
Cool.
meeting. Yeah.
What a nice result.
Yeah.
Thanks for sharing that with us.
My pleasure.